Good afternoon. I hope everyone has found lunch on either side over here. I'm Henry Cure, and welcome to Advances in Intraoperative Margin Management. I'm from MD Anderson Cancer Center, and I'm honored to help chair this session with my colleagues and friends. And I think we've got a really interesting program. I want to encourage everybody to feel free and come right up to the microphones and ask any questions. We're interested how this technology can actually influence your practices. And there's several different types of practices, so I think it will be interesting. We'd like to start, and we're going to have interesting cases, as you'll see, with Ash Kotari, who's a extremely well-known oncoplastic surgeon and chair of the breast tumor group at Guy's and St. Thomas in London. Mr. Kotari? Professor? Okay. Forgive the American titles. Okay.
So while you're having lunch, let's try and hold your attention to talking about 3D intraoperative margin assessment. So as we were talking to my colleagues from Asia Pacific, you guys get a lot of locally advanced breast cancers. We get a lot of early breast cancers because we have screening programs. And women are very breast aware. So they come to us quite early. And we have a lot of non-palpable cancers that we have, or with the advent of neoadjuvant chemotherapy, we do a lot of primary chemotherapy, downstage tumors. They become non-palpable, and so we require to remove them with healthy margins. So these are my disclosures, and they shouldn't interfere with anything I'm going to tell you today. We are now in an era of conservatism, like I said. We are trying to conserve everything. It's becoming more and more patient-centric, focused on quality of life. And wherever it's biologically safe, with the advent of perforator flaps, we have been able to do more for the patient in terms of disease, but as little as we could in terms of surgery. So de-escalation is here, as we heard in the morning as well, to stay. The problem that we have is trying to achieve a balance between a good wide local excision and removing just enough tissue where we don't start compromising the patient cosmesis. And one of the outcomes of a good wide local excision is that you would get negative margins, which is great because that's what we're trying to achieve down there. But you also get positive margins, and you can get a focally positive margin or a diffusely positive margin, and both these have different implications when you discuss the nuances in an MDM. So why are margins important? I think most of you know this, but just to quote the landmark paper from Husami, which said there was a very high risk of recurrence, 2.4 times higher if you have a positive margin versus a negative margin, and radiotherapy doesn't negate that. So what radiotherapy does, or what a negative margin, when the pathologist tells you, it guarantees is that there is no macroscopic residual tumor. There might be microscopic disease that radiotherapy would be able to deal with. Specimen radiography has been around for years. There is intraoperative specimen radiography, and then there is walk to the X-ray department radiography. It doesn't need a trial to tell you which one is better, although there is a randomized control trial if you're interested, which says that if you do it intraoperatively, it saves more time and is more efficient than walking to the X-ray department and getting it done. It ensures that the tumor is completely removed. You can look at the margins, especially with non-palpable tumors, microcalcifications, and make sure you got all the disease out, because that saves a second operation, that saves a lot of patient anxiety, and saves a detriment in terms of cosmesis. And medical legally now, with the clip and the coil and the mag seed and the Savvy Scout and the localizer, you have to show that you've actually removed the device. So it's a good medical record to have on paper to say that I have been there and removed the area that was localized. If you look at the re-excision rates or the wide local excision rates in the UK, it's 68% is where we're at. And if you look at the Guy's Hospital rate, we're somewhere near 79%. If you look at the re-excision rates across UK, it's about 19%. So this is clubbing both non-invasive and invasive. It's slightly higher for non-invasive, slightly lower for invasive, but if you kind of balance all out, it comes to about 19%. And we're somewhere around 19% at Guy's as well. what we've looked at is, if you look at all our re-excision data, 50%, and this is also borne out by the US studies, 50% of all the re-excisions that we do are needless. Now, we have a margin which is 2 millimeters for DCIS and 1 millimeter for invasive. We have not got the no-income tumor yet. I'm sure if we do no-income tumor, our re-excision rates will drop and the needless re-excisions will stop. Interestingly, the Americans are the only people who've actually set a benchmark, where they've said that you should aim for a 10% re-excision rate, no higher. And this is with everything that you've got at your disposal. And one of the tools that we're going to talk about today is specimen radiography. Now, the reason why you might get some low sensitivity of specimen radiography is that the resolution is not good enough. Now, these are old generation machines. The new ones, of course, the screens are much better. You've got the screen that comes with certain machines is the resolution that the radiologists use to report. The specimen gets compressed because of the pancake phenomenon, so there's a lot of 2D projection that goes on. We'll see how 2D images are slightly flawed and dense breasts. So this is the problem with 2D imaging. So if you look at the 3D specimen of the breast, you've got a margin that's positive to your left, which is that little dot. But when you project that and take that as a 2D image, what you will see is that the margin is clear. So if you look at a 2D image, you'll say, right, I've got the disease out, I don't need to do anything else. But when the pathologist comes back to you and says, oh, well, that margin was positive, you can think, how did that happen? So we started using the KUBTEC machine in about 2017. We were one of the first units in the UK to think, well, the world is moving to tomosynthesis. Why can't a specimen get the same benefit? And we got 3D imaging Mozart in 2017. And we bought this because we believe that, like in the breast, 3D will give you a more real picture, better resolution, and will reduce our re-excision rate. We liked it so much, we've got the second one on order, so that's coming very soon, and that's not because of what it does, it's because we are now operating across 2 sites, and we think it's beneficial to have it in terms of a machine across both the theater sites, because if you reduce your re-excision rates, it pays for itself within a couple of years. So these are a few cases that I wanted to show you. So this is a 64-year-old with a unifocal, and I want to thank Ms. Chowgle, who is my registrar, to help me get these images. She's in the audience somewhere. So these images are from our own series. Upper inner quadrant, spiculate mass, 64-year-old female. If you look at that 2D image, and if you look at that image there, it's exactly what I said to you. So we measured the closest margins, and the closest margins are 6.38 millimeters and 6.93 millimeters, as per that X-ray there. So I would have thought, great, this has all been removed. We don't need to do anything else. And then if you look at the cuts, you find that the margin is creeping more and more towards the lateral aspect. So we had the lateral and the deep margin involved in this specimen, and we had to go back and re-excise it. Now in this patient, again, 20 millimeter architectural distortion, lower inner quadrant of the left breast, far away from the skin. Compression views showed that it's exactly that, M5, 20 millimeters. And if you look at that excision again, the closest margin is 6.11 millimeters. That's the view again. Let's look at what the 3D shows us. If that video plays, the video is not playing. You have to trust me on that. How do I go back? Does that? Oh, okay, there. And again, you can see that the stranding now comes to the margin, and then it disappears again. So this was the lateral margin, the deep margin, because if you look at that's the bottommost cut. So you've gone from top to bottom, and the bottommost cut shows disease, and the lateral margin showed disease. So we had to go back and re-excise that. This is another case. Back in the days when MagSeed hadn't become that popular, we were still using wires, so very, very early, 2017. Needle localized wide local excision. Again, if you look at the 2D view, you think you've got it all out, till you look at the cuts, and then you can see it's creeping towards that margin there. So if you'd measured it on 2D, it would have been 2.98 millimeters using the K-view image itself of KUBTEC. But if you look at the 3D cuts, you look as you go lower and lower, it becomes positive. So this was an inferior margin that was positive, and we had to re-excise it. All these patients at re-excision had no further disease. The one with the deep margin, we don't take deep margin because we take the fascia. but all these patients had no further disease. So we looked at this presentation, which was made in SABCS by another unit in the UK, and who said when we used 3D versus 2D, we got our margin re-excision rates down at 41%. So we said we already have 3D, so what are we doing wrong? So what we did was we looked at all the patients that have had positive margins. Now the surgeons and the radiologists were blinded to this. So we sat down and looked at the margins that the surgeon thought was negative, but turned out to be positive in pathology. And we discovered a common theme, that they looked at the 2D image, didn't bother getting cuts, and they said, this I don't need to do anymore because I know what I'm doing. So we went and looked at the cuts, and we got one of our junior colleagues to look at the cuts and say, if you had a chance, would you excise any of these margins? And what we found was that if we had used the 3D cuts, we would have reduced our margin re-excision rate by about 47%. So looking at the 2D image, we would not have re-excised it, but if you'd used the 3D cuts and the TOMO function of the KUBTEC, we would have reduced our re-excision rate by a further 47% from 19%. So we would then come back to the American College of Surgeons 10% benchmark. So with that, I'd like to thank you for your attention and like to invite you for the India Breast meeting, which is on the 5th, 6th, and 7th of January in Mumbai. And looking forward to seeing you all there. Thank you.
I think we'll hold some questions until all the speakers are finished, and keep track of your questions because I certainly have several as well. I'd like to now introduce Dr. Andreas Karakastansis. Is that okay? All right, okay, I've been practicing. Andreas is a well-known innovator in our field and serves as a senior consultant oncoplastic surgeon at the Akademiska University Hospital in Uppsala, Sweden. Thank you.
Thank you very much for that. You will have to tolerate the hiccup that I have. But I would like to lift some points that have to do, especially with the clinical relevance of methods for intraoperative margin assessment or prevention of the need for re-excision, especially in oncoplastic breast conservation. These are my disclosures here. So a specific background to understand where we come from. At Akademiska, our profile is that we perform breast conserving surgery in 90% of patients, a number that goes up to 97% for tumors up to 3 centimeters. And the one out, corresponding to the re-excision rate, is the majority of these cases. So our re-excision rate is a 5% that we try to hold on to dearly. Re-excision is a problem, apart from the things that Ash mentioned. We are talking about an operation that per se has a higher complication risks. When we are talking about surgery following adjuvant chemotherapy, there is systemic therapy delay, and this may cost in oncological outcomes in the case of patients needing adjuvant chemotherapy. And the accuracy of the procedure per se is uncertain, especially in the field of oncoplastic breast conservation, and once somebody has performed extensive remodeling of the breast tissue, or we have large and long cut surfaces. And last but not least, of course, the financial toxicity and the longer queues, because any patient that needs a re-excision will have to take the place of a patient waiting for surgery. How to prevent it? Well, you should not prevent re-excision by going for upfront mastectomy. Routine shavers have been established as a very good way to do that. But in our setting, it means prolonged operational time and unhappy pathologists because they have to deal with a lot more specimens, do their immunohistochemistry. They have to treat any piece of tissue as a new tissue per se. And this is not always the possible case in patients that are marginal for breast conservation. So you need to plan and you need to execute what you have planned correctly. The intraoperative ultrasound has shown very, very promising results. And since the COBALT trial, a very big randomized control trial, we have had a very clear image of that this is something that works. But it needs training and expertise in order to be able to implement it ready for production, so to say. And there is the case of lesions, like the case of DCIS with microcalcifications, where you actually need expertise to be able to treat the ultrasound with that. And the team of Isabel Rubio has shown how you can clip the middle of the lesion and then make some measurements intraoperatively. But still, we are talking about something that requires specific training and expertise. And then there is the intraoperative margin assessment. And what do we have in the armamentarium? Well, we have guidance devices, but recent randomized controlled trials did not show any improvement of data with regards to the use of a margin probe. We have the frozen sections that certain centers utilize, but it is frozen in the sense that it is expensive, it is resource consuming, and it is not always 100% accurate. So you may leave the theater with the notion that everything is okay and still land in a surprise. The standard specimen radiography that Ash touched upon is routinely done. It has got varying results, but it will prolong the operative time because you formally need the radiologist to check you out during surgery so that the patient can be sent to the recovery room. And it is less accurate in dense breasts and in the usual suspects like in microcalcifications or patients with invasive lobular carcinomas. There have been discussions and development of a MRI-based margin assessment, and the available data suggest that the accuracy was approximately 0.8 in post-hoc data, but the time needed to do that for every cut surface may be a challenge, and the compatibility with marks and tracers, especially for somebody that wants to work with MRI interference techniques, may be significant. And finally, the pegylicianine fluorescence-guided surgery study recently published from the United States, where they showed reduction by 14% with a low sensitivity, however, but good specificity. But this did not address the problems in any setting. You have to have a very particular setting where the re-excision rate is high in order to be able to make so impressive changes. And the other thing is that the adverse effects were 1.6% with the grade 3 being 0.5. And I will have to remind you that the toxicity, the severe toxicity of the blue dye is 0.1. And it is enough for us to want to abandon it, especially in the setting where we do more and more day cases and the patient needs to go home and we need to be well aware that everything is going to go well. So moving forward, why tomosynthesis? Ash touched on that as well. The specimen is 3D, and you need something that is three-dimensional to be able to tell you what things look like. The tomosynthesis in the diagnostic setting will outperform the mammogram in dense breast ILC and microcalcifications, and this is the thing that we in real time want to know about when we're doing surgery. You need something that is in the theater, and not only the direction of the margin, but also the depth of the shaver. This is also a thing that is important to do. And I will take you through three cases, which I call them soaks from reality because they are three cases that kind of represent challenging cases when you have to do breast conservation in this setting. So the dense breast with calcifications, where you need to understand what's happening. The small breast, where you need to go close and you need to remove, as we would say in Swedish, lagom, which is as much as required but not more than that. And the complex oncoplastic lesions, where you aspire to preserve the breast. So you have to take my word for it, but this is where the lesion is. There is a big solid lesion in the upper inner quadrant, followed by microcalcifications going up and parasternally, as you see in the picture. And this is how the lady looked like, and she wanted breast conservation, of course. So this is how a traditional specimen looks like. So this is what the radiologist will look at, and they will tell you everything is okay or it is not okay. So what did he tell me? It should be okay for the tumor. I cannot tell you much about the microcalcification, but I guess it should be all right. And this is an experienced radiologist, but this doesn't sound very comforting during surgery. However, with the Mozart, 20 minutes earlier, I could see how the specimen looked like and how everything looked like. And the quality of the specimen by bidimensional radiography is much better, as you can see. And I have chosen to tell you that the minimum margins were 1.5 and the maximum margins were 5. So we took as much as we needed, but not more than what we needed to remove. I have not had a postoperative picture of the lady because she's a true story at the Canary Islands on a holiday now. True story. So the small breast, where you need to go close. See, so this is a small lesion here. You can see it on the mammogram and you see it on the ultrasound. But it belongs to this patient. And this lady, who's 82 years old, she's very adamant that she wants to have a good cosmetic outcome. And they are entitled to. So the specimen looks like that. And then the radiologist told me, well, I cannot tell you anything. And a little bit later, I did an ultrasound and it should be all right. Another radiologist is good, but still, you don't get the type of information that you want because you do not really want to drive an 82-year-old to a reoperation. But 20 minutes earlier again, in a small specimen, you see that it was a 2x2, 2x5 by 2x5 specimen. This is what I got from the Mozart. And interestingly, if you want to see slices, because this was a deep-seated tumor, going deep, I know that everything should be okay by that. So I had this outcome, this patient preoperatively and this postoperatively. And last but not least, the complex oncoplastic excision, where you have a lead lesion with a lot of calcifications, and you have an impressive footprint, and the patient has not responded very well to neoadjuvant chemotherapy, and you need to know what you're going to do. And this is how it looks like. This is how the specimen looked like. Looks good, but I cannot tell you anything about the nipple areola complex because that was a superficial tumor. But again, 20 minutes earlier, I just cut it off because the tail is not that important. In a massive specimen, as you see in the dimensions, this is how it looks like. This is how a more superficial slice looks like, and this is where the margin looks like. And I know that this is the superior margin that is still 7 millimeters from the retroareolar margin. And these are the calcifications in a higher level. So minimum margin inside to 3 millimeters, maximum margin invasive 5 millimeters, and everything went well. So conclusions. Specimen tomosynthesis is fast, easy, and efficient. It allows for tailored decisions in different clinical scenarios, especially when you're dealing with the notion of avoiding doing more. And I am confident in that future data generation will standardize outcomes and help dissemination of this technique further. Thank you very much for your attention.
Thank you. Those were great cases, real world. Next, we have Dr. Michael Alvarado, who's a very well-known innovator and surgical oncologist, professor at the University of California, San Francisco.
Thank you. Let's see. Thank you so much. It's great to be here. Great first couple speakers. I'd just like to give you a little bit of some background at our institution at UC San Francisco. Obviously, as been stated, we want to decrease positive margins, decrease re-excisions, try to improve cosmetic outcomes by not taking too much, but also trying to avoid a second surgery. Patient satisfaction, obviously, is in that area, but also societal cost. And I think that also is a big part of making sure we don't have reoperations. Of course, for patient satisfaction, but the amount of money that can go into reoperation on more of a societal cost can be rather significant. And then, of course, the possibility that happens sometimes where a woman needs a re-excision, and instead of going for a re-excision, she starts to get nervous and worries and decides for mastectomy. So I think that sometimes can be the trickle-down effect of having problems with margin assessment. Now, the story from our institution, when we first were looking at intraoperative assessment, we were at a smaller cancer center originally where the operative theater was actually rather close to breast imaging. Basically just down one flight of stairs and maybe down the hall a little way. So not too far. But we still needed to take the specimen, put it into a little plastic bag, and then have someone carry it to breast imaging. And then typically the technologist would put it in the mammography machine. And about 45 minutes to an hour later, we might get the information that we needed. And then, of course, the question was, well, how did you orient it? And the technologist says, what do you mean? And we say, well, what's up and what's down? What do you mean? And so you can see it could get very complex and problematic in that sense. So that was when we were at a small institution. Luckily, we do have intraoperative assessment now with the KUBTEC Mozart system, because in our hospital now, it would probably take 20 minutes just to walk it over to breast imaging. And so it could be a real problem. So that was a real issue for us in terms of understanding the margin. You'd get this image back, it would take some time, and it really wasn't that helpful. So moving to having something in the operative theater was extremely beneficial at our institution, cut down on operative times, and really made us more confident with our resections. And then here you can see in our operative theater, we have one basically in the operating room, as you can see here. So that's really nice. Tomosynthesis, this is, you've heard already from the others how much better the tomosynthesis is compared to the 2D visualization with the slices as well, and be able to run through that and see not only the peripheral margins, but also the anterior and posterior margin. Before that, we would do such things as take a 2D image, and then I'd try to get the nurse to turn the specimen on its side so you get a little bit more information on anterior and posterior, but that didn't always work as well. Again, same type of data that you heard, the high sensitivity facilitating reductions and re-excisions, and really using these tools as well. And then really, I think it was just, Andreas touched a little bit on it, but in the United States, it's become very fashionable to do shaved margins and just kind of, just shave them all in. And I think it's not a true shave margin. I'm sure you're all well aware of some people that take little things here and there. And as was pointed out, that means the pathologist has to look at all those things. And it adds a tremendous amount of time. So if you have 3 breast pathologists and you have 6 breast surgeons that are operating every day, and now instead of having a lumpectomy, you have a lumpectomy and 6 shaved margins, as well as the sentinel node, all of a sudden that amount of work goes way, way up. And pathologists like to really look closely, right? So they may see one atypical cell in one shaved margin, and next thing you know, there's 32 studies that are done with immunohistochemistry. So it really does take a lot of extra work for our pathologists to go through those things, and being able now to move to more of a focused shave margin situation, as both Ash and Andreas were saying, where you can actually see and it can direct you to actually where you need to go. You've seen this already from Ash, and this really shows the concept of moving through the specimen and not just seeing it for the 2D object that it would be. So just some of our cases that I'll just share some images as well. So here is a 62-year-old with an invasive ductal. And again, the great thing is when you put it in the machine and you get your images, you get the optical view, which is kind of the standard view, which you can kind of think about what it looks like when you took it out. You get the 2D view, and then also the K view, which sometimes gives you even a little bit more crisp and really nice identification, especially of the calcifications. And then here you can kind of see when you scroll through it, you get a sense of how deep the clip is in the seed as you move through, and you can see very nicely that it truly is basically in the middle of the specimen and not too close to the anterior or the posterior size. Another issue, and as more and more women become screen detected and start identifying things like calcifications and such, again, you can see for this DCIS patient a really nice evidence of those calcifications. And as Andreas was showing in the the old machine that we used to do, which was just a standard 2D view, you wouldn't get a very good picture. Now, here what's nice is that the 2D view is actually a reconstructed 2D view from the system, which gives you much more crisp and clear images. And then the K view, you can see here, really illustrates the calcifications that you get a little bit better than the standard 2D view. You can really see as they start to stretch out in different projections. And this is the standard 2D view that you can see, and then the K view that really gives you really crisp identification of those calcifications, which are the ones that are important for identifying how far those stretch. And you can see starting to get a little bit close down here on the inferior aspect. And then, of course, you also have the tomosynthesis where you can see those calcs as well. Nicely, you can see that they're in the middle of the specimen, but down here you can see them kind of gives you a better idea if you are going to do that shave margin that it's not really anterior inferior or posterior inferior, but more kind of right in the middle of where that cavity was. So really gives you a better focused idea of where you might want to do your focused and kind of directed shave margin. And then here's one 52-year-old with more of a bracketed area, both invasive ductal and DCIS, and then the MR identifying a third area. And so, as Andreas was saying, now we're starting to do these larger resections. So you definitely, if you're doing the oncoplastic closure, want to make sure you can try to avoid a re-excision, because trying to go back and finding that can be very difficult. The other nice thing about the KUBTEC is the area for which you can put the specimen in. So it actually fits a very large specimen, which is great. We've actually also put in mastectomy specimens sometimes to look at clip placement on our mastectomy specimens. But again, you can kind of see here how nice the 2D view is, and then the K view really giving you a nice crisp idea of where those lesions are. And then with the 3D view, the tomo, you can see that the anterior is a little on the close side. As you can see, she had her first biopsy outside where they used the other localization device as the biopsy clip. And then when she came to us, we switched to which we use as the MAGSI. But you can see that kind of at the beginning there that it does appear to be kind of close to that anterior surface. So this gives us a nice information to realize to go back to the anterior aspect to try to avoid the re-excision. So again, for us, it's been great moving from nothing in the operating room to the first generation of 2D imaging on kind of a smaller platform to now having the tomosynthesis on the larger area, which has really reduced the re-excision rates, decrease overtaking tissue, and really gives us the better way of focusing those shave margins so we're not contributing to the extra work for the pathologist to do, the cost, the time for those as well. So I really appreciate your time, and thank you so much.
Thank you. Those are great talks. I have several questions, and I'd love for you to put the lights on out in the auditorium, because I'm interested to hear my other colleagues from different places on their challenges and interest in this. And I'm just going to start with what I think is the hard question. It's obvious that this technology is superior than what we have. One is a 2D or orthogonal, several images. What about the cost? Could each one of you tell me, I'm not going to ask, I don't even know how much this device costs, but it's very advanced. Can you tell me what you had to do in your own institutions to bring this technology in?
I could start, since I am somebody who is currently trialing it, and I can give you a little bit of the background of how things work in Sweden, because we are talking about a state finance system, so you really need to be able to make an argument. So you need a trialing period to see if this qualifies to go in a clinical trial to begin with. So the 20 minutes I spoke about, which is the time that you would need, as Michael said, until somebody from the theater will have to take the specimen to the radiologist, and they will have to do whatever they have to do, and they have to reach back to you through the telephone and upload the picture on a screen or something like that, is a very crucial time, because if we are talking about the standard of a wide local excision that should be something like 45 minutes operative time with a sentinel lymph node biopsy, it is not an uncommon scenario where the patient is still asleep, you have sutured, you're done, but you are not allowed to wake the patient until you get confirmation. So we are talking about something that will decrease operative time in standard procedures by approximately 20 to 25%. This is expenses that need to be accounted when we are talking about things like that. Preventing a re-excision is also, it has been studied extensively. The other thing that needs to be highlighted as well is that you can actually have a much better idea of what to do and when to do that when you need to re-excise as well, because what we have decided to streamline at Academiska is that we will from now on be doing the ink markings of the margins instead of the pathologist once the specimen has been removed. So the optical view in the Mozart will be telling radiologist and pathologist the exact orientation of the specimen, which means that this is something that can potentially allow for focused re-excision when it comes to that. And what we are doing, what I have been doing for the time that I have been testing that, is that if re-excision is needed, I will do it at the same time, and I will have a pre- and post-shaver Mozart picture for everybody to assess afterwards.
Okay, I noticed that you said during your talk that a radiologist was doing the image, and Michael too, looking at the images. Are they involved with the Mozart imaging?
They are involved because once everything is uploaded in the PACS system, they can review it at real time.
But is it real time that they're looking at it with you?
It will be streamlined real time during the trial, and this is what we want to show. We want to show the reduction of operative times on that.
Yeah, I think you hit it, but the same thing at MD Anderson, and at the tremendous costs associated with delays in the operating room. And I'll just tell you, we stopped doing frozen sections on T1, T2 invasive breast cancers with mastectomy because often we're not even dissecting those patients anymore. So that is getting shorter now, so we have less and less time. Do you have a question? I'd love to hear from the audience.
Yeah, no, I had two questions. I think you probably just answered one, which is the involvement of the radiologist comparing pre-surgical films with the specimen. And so is it standard to ask the radiologist then to compare preoperative imaging with the specimen?
Well, so at our institution, I would say probably 80% of the time, it's fairly straightforward for the surgeon to see the image, and it's pretty obvious that, yeah, we got it, there's no issues, we're not sure. But there will be cases, where it's like, well, there was a second area of calx, and I'm not really sure, does this look like the same calx that you were referring to? We may have not have, it been maybe 10 millimeters away or something like that. So we do engage with them sometimes, and it's uploaded to the PACS system. We just call radiologists, hey, can you take a look at it and see what you say? But most of the time, we don't engage the radiologist. They do review them and sign off on it medical legally, I think, in the U.S. at our institution. But we don't really engage them in the OR unless it was one of those cases that was a little bit complicated, or we weren't really sure, are these the same calcs that were malignant looking calcs, et cetera?
Are they, just for clarity, are they reporting on the images after the patient leaves the operating room?
Yeah.
Because that seems like it could be a medical legal issue if they call something that we didn't see.
Yeah, but it's, they don't really, what they say is usually the clip in the seed was located. They don't really comment on. Yeah. Right. So
right.
I agree. If they were saying, he's gotten all the calcs or she's gotten all the calcs versus something like that. But they usually just comment on the seed and the clip.
I think that's really important. Is for at MD Anderson in Houston as well. Most of the time, interestingly enough, they are talking with me, the pathologist, real time. And even their reports, I'm beginning to notice that they're not saying there's tumors obviously at the medial margin or the suspicious abnormality was removed, the clip and whatever localization device we use. So I think key to this is us multidisciplinary, talking to everyone, working it out, communicating. I think that's really important.
If I could ask just one quick question. What is the limitation to this technology? You've reduced margin re-excisions, but you haven't eliminated them. So where are you missing?
Yeah, I think you hit a real interesting point in the field. So obviously, the margin positivity rate will be dependent on the histologic evaluation of the specimen, like how much and where. I heard one of our speakers say that the pathologists will utilize the images to select for margins. I mean,
I think there's a
look
really-
what's going on with neoadjuvant systemic therapy, you know, in triple-negative HER2 positive.
Yeah.
70% PCR rates, including the DCIS and invasive. So there we're already going to the limit. We want to go as far as possible eventually.
I think also, as Andreas was saying, I do find for my larger oncoplastic cases and a lot of DCIS patients, we tend to ink our own specimens, and there's a less issue of margin positivity. I'm not sure if anyone spent much time, or if you do spend time when you're training, watching the pathology techs or the residents or whoever that ink the specimen. They're not subtle. It's kind of jabbing the thing, they're painting it, they're smushing it, you know, it's already sitting formalin, it's all this stuff. And I think that there's an issue between inking it in the OR with positivity rates versus not as well. So I think that also could make a big difference.
So the data that I showed you, I mean, we are not as fortunate to have real-time reporting. So we don't have frozen section, we don't have real-time reporting. So we look at our own images, and then those images are reviewed in the MDT, so it's too late by then because the patient has left the OR.
Right.
But the 204 margins that we're looking at, those margins have been inked by us. So it's part of another study, which is the Cherenkov luminescence imaging that we're looking at. So we're inking those margins. Now, what I showed you was the first half of the data, which shows a reduction of about 47% if a surgeon reviews them in 3D. The next part is that a radiologist is going to go through them.
So you have 47% reduction of positive margins, re-excisions?
Yes.
With the device?
With this device.
Okay, that's a major, that is in the range of taking large cavity in everybody.
Exactly.
Yeah.
Now
And Michael made that point was really, you got to get the pathologists on board of the technology, and you hit it. We're going to give them less work. Right. So that's the multidisciplinary discussion around this.
And the second half is we are now getting a radiologist, a breast radiologist, to look at those planar views again, all the cuts, and say, would he have excised more? So then that would inform whether then we need to go back to real-time reporting like these guys do to further reduce our re-excision rates and see whether we can get it down below that 10% mark.
Yeah. Thank you for being brave enough to stand up. So we're going to need some more people, too.
Great talks, then great session, thank you. To Andreas, but potentially to all the panelists, MagTrace. So we currently are in a situation where it goes to another building to radiology, so we've got a lot to gain. But when we have MagTrace in our specimens, they almost always have to do a re-exposure. Because no matter how much you tweak up the windowing on our system, you cannot penetrate it. So the question is either with your K-view, or can you alter the energy of exposure to overcome MagTrace?
Yeah, that's a good question. So there is a way to avoid that, and it is injecting preoperatively because the fluid component has disappeared within 4 hours. So we never have these types of problems. It does not collide in any way. The other thing that I would like to point out, I mean, in Sweden the system is very clear. It is a medical-legal issue that the radiologist will have to tell you the margins are okay. In Uppsala specifically, there is a standardized protocol when the telephone rings in the theater, it is going on speaker, and the questions are, is the clip and the marker? How are the margins radiologically? Do you think I need to excise more, and if so, towards what direction? So these answers have to be clear so that we can make the decision. And as I said, it is not uncommon that you're done with surgery, you're sitting and rolling your thumbs there, but you cannot tell the anesthesiologist that the patient can wake up until you get this. So the benefits are important. With regards to eliminating the risk of re-excision, I think that we will not find a system with present technology that will allow us to eliminate the risk of re-excision if we are looking at specimen radiology in general. What we need to do is that we need to aspire to limit the re-excisions to those that have to do with occult radiological disease. I mean,
Local what?
Occult radiological disease.
Occult.
Occult.
Okay.
Like the case of micropapillary DCIS, for example.
Yeah. that's a difficult case.
So, and I think that we are all aware that any type of radiological modality will not be able to address that. But if we limit the re-excision and only to those cases, and if we can limit the operative times, I think that we have made a good step forward.
Yeah, one interesting thing, and if there's anyone from the Netherlands, when I was there, I heard that they routinely allow a little bit positive margins. I can't remember the exact amount, and they just do the radiation. So that might bring us closer to less and less excisions together with really good technology.
I agree with that. I think we are people, the world is paying a lot of attention to margins as if it was in 1972 and we didn't have good chemotherapies, targeted therapies, good radiation, endocrine therapy. I think it's become this huge thing. I mean, every meeting we talk about it. So I'm not sure, as you're saying, that it's going to be such to a certain, like a focal positive margin on this patient who's HER2 positive that's still going to get, a year's worth of TDM1 or something like that. But then to the other question about MagTrace, I've been doing the Mag Total with MagTrace injection with seed after visiting Andreas now, so for, since March or April. And we do all of ours pretty much either the day before. I've done some same day. He's told me that I've seen that it works. I've watched him. I get a little bit nervous with the same day injection, but it's usually 4 to 6 hours before. Now, of course, that depends on your system and your patient population, and are they coming from far away? Can they come in? Can they wait and such? But I haven't had any problem with intraoperative KUBTEC Mozart assessment with the MagTrace so far with the injections previously.
Ash, I have to ask you, we have rumors in the U.S. about the NHS and financial situations. What was it like how did you get them to do that?
To buy the second machine?
Yeah. Oh, to buy a second machine?
We bought a second machine.
Okay. You must be somebody important.
No. It was very
Do you know Meghan Markle?
It was very simple. So just a point in the margins before we move on to your question is, I don't know whether you guys have this in the US, but we have a UK small study where we're having small tumors excised with vacuum excision. And they won't be able to comment on margins. But the radiotherapists in the whole world is happy with that. And here we are focusing on focally positive margins, like you said, and whether it makes a difference. And like you said, in the Netherlands, that's why I showed you the picture of focally and diffusely positive. So 2 millimeter margins in the Netherlands, they wouldn't go back and excise it because radiotherapy would look after it. It's only if you have a more diffuse margin.
Yeah, same in Anderson. We decreased the margin to
no
tumor on ink.
Coming to your question on 2D and 3D.
For DCIS as well. If they're getting radiation, sure.
Oh, wow. Okay.
Same here.
So no tumor on ink for DCIS?
Yeah, because of Henry's paper that he published showing that when they get radiation, there's no difference with thinner margins.
Yeah.
And in the UK, we are trying to revisit it by publishing a new paper and a new analysis saying 2 millimeters or 1 millimeter. So I think the world is divided there. So the first business case was made exactly on the grounds what Andreas said, was saving theater time. So we had McKenzie's coming that time, and we used their analogy because McKenzie's said a theater table only makes money if the patient is like an aircraft. If it's flying, it's making money. If the patient's sitting there doing nothing, you're not making money in it. So we used that analogy, and we said, we're saving time, specimen going to X-ray, coming back. The re-excision, at that time, we were 30% with the 2D. So it was very high re-excision rates.
Yeah.
We brought that down to 19%, so that's how we justified the cost. The second machine was very simple. They want us to move to another building, but they want us to move for only 3 days to the other building, and 2 days we have to operate in this building. So we said, provided everything's equal, we don't mind moving. But the NHS is extremely cash-strapped at the moment. That's why we don't have same-time radiology reporting, frozen section, nothing.
I can imagine it will give more space to get more patients in, so it would help the NHS in their troubles with that.
Get the throughput, yes. But again, if you reduce because like you said, lots of women today, the mastectomy rates in the UK, if you look at the mastectomy reconstruction rates.
Let me ask you just one last question. We're going to have to end in a couple of seconds, but what trial do you think we could do as surgical oncologists, multidisciplinary surgical oncologists, to really just put a hammer, just say this is the best technology. There's evidence, and do you think we have to involve patient advocates? What would you do?
For an ideal trial for margins?
to purchase this type of technology in our own institutions? What kind of study do you think we need? You already provided a lot of evidence, but what would really make it a high-level study?
Prospective,
Yeah.
randomized, looking at, not only just looking at margins, looking at specimen weights, looking at the ultimate cosmetic outcomes, because some people will take a wider specimen, a bigger specimen, get negative margins. And what we are trying to do here is look at the nuances of how much we need to take. And even in the re-excisions, we are trying to focus on how much to take. So it requires, and of course, the patients need to be there as part of it to say, if maybe the technology involves injecting some kind of contrast or some kind of, any kind of contrast.
I think the gold standard, as you mentioned, would be, of course, the randomization. I don't know if the patients would agree to something like that in the U.S. if the technology is superior. I think in the U.S., all we would have to show is that the re-excision rates were as good or better, and that we saved operative time, because that is so critical to have patient volume, keep them high. You guys were fantastic. Thank you. These are our real-world problems, and thank you, audience, for participating.